Thanks, Mel, and thanks, Jason, for the invitation. There are many similarities between my talk and what we just heard about in Scotland, and I'm going to focus more on some of the modeling that we've done in Canada to try to address to determine the exact disease burden of hepatitis C here, and then also determine the impact of use of more effective therapies that have recently become available. These are my disclosures. So as you heard, the prevalence of hepatitis C in Canada is roughly 0.7, 0.8% of the population. And the good news is that although the prevalence is declining, the burden of disease is increasing. This is some nice work from StatsCan, where they look at the number of admissions between 2005 and 2010, according to birth cohorts. And you can see that the major birth cohorts affected of having these increasing rates of admissions over this time frame are those in the baby boomer population. And of course, their disease is progressing due to aging, and then they're developing these complications. So we've looked a little bit ourselves at the burden of hepatitis C in Canada in terms of hospitalizations using the CIHI database, and really these results were corroborated. We saw that between 2002 and 2010 there was a 1.4% annual increase in hospitalizations, and I would assume that this increase will be ongoing if we looked at a more updated cut of the database. We also have done some modeling to describe the burden of disease, and this is a paper many of the audience was involved in. And what we described in this paper was that last year the prevalence was estimated to be roughly 250,000 individuals. And again, although that prevalence is declining here, shown in blue, we're seeing markedly higher rates of complicated liver disease like decompensated cirrhosis, liver cancer, and hepatocellular carcinoma, or the requirement for liver transplantation. Now, this is the data looked at in a little bit of a different way, where we tried to plot the disease stages of Canadians over time from the 50s out to 2035. And what you can see is that if you focus on 2013, the proportion of patients in the red or above, which are those with cirrhosis or complicated cirrhosis, that they represent about 9% of the population. Now, what we modeled was that if we continue using the same treatments we've been using for the last few years at the same treatment uptake rates, that the rate of, or the prevalence of those complicated cases is going to over double, so that we'll have roughly a quarter of our patients in 2035 with complicated disease. Now, if you look at this in another way, sort of the glass half full picture, you might also say, well, right now we're in a situation where over 90% of our patients have non-cirrhotic disease. So this is a great opportunity to intervene with these new effective therapies to prevent those patients from getting complicated cirrhosis. So we all know about the benefits of antiviral eradication in terms of liver histology, quality of life. What I'm going to focus on for the remainder of this talk are the clinical complications of decompensation, HCC, and mortality. And the real question is, we know we can improve these things on a patient level basis by curing patients, but how do we use these therapies most effectively on a population level in order to reduce the burden of disease in Canada? And so we have done some modeling, which I'll present later in the meeting, and will be the main focus of the remainder of my talk, to try to look at this. And we wanted to determine whether or not it would actually be feasible to eliminate hepatitis C from Canada by 2035. So over the next 2 decades, can we eliminate infections, and cases of decompensated cirrhosis, HCC, and liver-related death. And we define that as over a 95% reduction in these outcomes. And the 2 main things we wanted to look at were what type of patient numbers do we have to be treating to achieve these outcomes? And also, do we need to use any fibrosis thresholds for initiating treatment? Because, of course, these therapies, as we heard, are very expensive, and perhaps some rationing of therapy may be necessary to achieve these goals. So we used a system dynamic model, and essentially we modeled patients from 2014 to 2035. We considered 36 cohorts defined by age and gender. And we tried to calibrate the model with published data where available, and particularly that published from Canada. And again, this model has been designed to measure the burden of hepatitis C, and it's been used in Canada as well as in Scotland, et cetera. So it's a well-validated model. And we used the typical disease progression model where we considered all the different stages of hepatitis C infection. And of course, we modeled the impact of antiviral therapy on all of these different stages. And in a small proportion of patients who had cirrhosis but were cured, we still considered them at a small risk of liver cancer. So we made a few assumptions to populate this model, and actually you heard a few of them already. As mentioned, we estimated there were roughly 250,000 Canadians with hepatitis C. We estimated that about 70% of them had been diagnosed, which I think is debatable. We also modeled that annually 7,600 patients would be diagnosed in Canada, and that 4,000 new infections would occur in Canada. Now, we took disease progression rates from the literature. We considered the proportion of transplants done in Canada as being liver-related. We got data from CORE. It's roughly 1/3 of these. And we also adjusted for the increased mortality that Dr. Hutchison described in terms of patients who have hepatitis C due to their underlying risks. We use the Canadian genotype distribution as been previously reported. And we also considered that we could only treat a certain number of patients a year. Now, in 2014, we started this model. We assumed that we would treat 3,600 patients, and that's based on some data from IMS Health. But then what we did is scale up those treatment numbers as shown here. So in 2015, we assumed a doubling of treatment rates. In 2016, a tripling. And then by 2018 and beyond, we felt we could quadruple the number of patients that were treated. And of course, this is because we'd be using more interferon-free therapy, short durations, minimal side effects, et cetera. And then we did a sensitivity analysis where we modified the number treated annually, starting right in 2015, anywhere from 1 to 5 times our base rate of 3,600 per year. I apologize, this is probably a bit small for you to see at the back, but we made a variety of assumptions about when these new therapies would be available and what patients would be candidates for different antiviral therapies. Now, the general gist of this table is that as we got interferon-free all oral therapies available, the types of patients we'd be able to treat would become more liberal. We treat older patients, we treat patients with decompensated disease, et cetera. And we took data from randomized trials to model the SVR rates from these for these therapies, but we reduced them 5 to 10% based on what regimen we were using to reflect real-world rates of cure compared with registration trial rates. So we modeled a few different strategies, and I show these 4 here, but in fact there are actually more. The first is the sort of base case model, which I showed you earlier, and this assumes basically that we would use the first generation protease inhibitors and PEG-RIBA at the same number of patients treated out until 2035. So this is really a pessimistic view of what we would be doing. In red, we considered the available new therapies with better cure rates, and so we modeled increased cure rates, but we didn't model an increased treatment uptake. And then in the third category, we used a variety of different strategies where we tested different fibrosis thresholds for introducing therapy, anywhere from only treating patients with F3 or above, or treating all patients regardless of their fibrosis. And then lastly, in green, we modeled what I call a progressive strategy, which I think is probably most reasonable, where we initiate treatment in patients who have more advanced or stage 2 or above disease first. And then once we treat the majority of those patients, we start treating patients with milder disease. And here are the results of the essentially the increased SVR scenario. And so what this shows is a number of cases of infections and then complicated disease that we would see between 2014 and 2035 if we use these new wonderful therapies, but at the same treatment uptake rate that we're doing now, so 3,600 patients per year. And what you can see is that the number of viremic cases would drop by 30% over this time frame. But unfortunately, the number of complicated cases would increase, particularly HCC cases. We're seeing over a doubling of cases. So the message here is that even though we're using these very effective treatments, if we don't treat enough patients, we're not going to change outcomes. Then we wanted to look at these different strategies in terms of fibrosis thresholds to see how we could impact viremic cases and then these cases of complicated disease. And this figure shows the number of viremic cases, or the prevalence that we would achieve in Canada. And what you can see is that in black, this was the base case where we're using the old therapies. Even if we use the new therapies, with higher SVR rates, we won't really achieve a big reduction in prevalence because we're not treating enough patients. And then as we reduce our fibrosis threshold down to F0, you can see that we're able to have a larger impact on prevalence. And Dr. Hutchison showed this quite nicely. It's quite intuitive. If you treat patients with milder disease, the prevalence is going to go down greater. On the flip side, we looked at the proportion of patients that would get complications, and perhaps focused on the top graph, which is the decompensated cirrhosis figure. You can see, as mentioned in our previous paper, we see an increase in cases of decompensated cirrhosis. If we use interferon-free therapies, we'll still see an increase, but although this will tail off in a couple of decades. The best strategy for decreasing these cases of decompensated cirrhosis is, in fact, treating patients with only with F3, and then once the patients are treated with F3, treating patients with milder disease. So you can see that you're impacting the complications of the disease more rapidly by treating patients with more advanced disease. But what you should also notice on this figure is that by the end of 2035, all of these strategies, they sort of look the same. Okay, so you sort of get to the same place in the end, but you have the road is a little bit different. So this shows the data in a little bit of a different way in terms of the proportion of these cases that we would prevent between 2014 and 2035 if we use these different strategies. And it really echoes that last comment that I made. I mentioned that I thought this progressive strategy was sort of maybe the most reasonable. You can see that by 2035, we we reduce the number of viremic cases by over 95% and virtually eliminate cases of complicated disease. On the flip side, again, if you use our base case scenario, you're seeing an increase in cases of liver-related mortality, for example. So the other question that we had is, if we treat more patients, how will this impact the burden of disease over time? And obviously, if you treat more patients, you're going to see larger reductions in the number of viremic cases and the number of complicated cases. And this is, of course, demonstrated nicely here. Again, depending on how many patients you treat, if you treat more patients, you'll just get to the bottom line quicker with more treatment uptake. So it's quite intuitive. Now, what we did find is that after we treat over 10,800 patients annually, that by 2035, we really didn't see a big difference in terms of complications of the disease or really viremia. So it seems like if we can at least treat 10,800 patients per year, over the next 2 decades, we will be able to do a good job of eliminating viremic cases and complicated cases. Of course, one of the important factors, which I essentially glossed over at the beginning of this, is that if you want to treat so many patients, you need to feed patients into the model. And so that gets at what Dr. Hutchison was talking about, improving diagnosis rates. And you can see here, based on the red curve, that if we limit the number of patients that we're able to diagnose over time, then we start to, although we see an initial benefit in the number of decompensated cirrhosis patients or cases that are prevented, you start to lose that. So over here, we need to be doing more case finding in order to feed the system so that we can get these patients onto therapy. And these figures just show some of the magnitude of that. So just to summarize, I think under some reasonable treatment assumptions, I think we can probably eliminate hepatitis C from Canada within the next 2 decades. in my opinion, this progressive strategy of treating patients with the most severe disease first is maybe the way to go. And I know there's a debate on this later on, so we'll see what the guys have to say. As I mentioned, over about 11,000 cases per year. We essentially can get similar benefits over the next 2 decades in terms of reducing the prevalence of disease and complications. And hopefully, as I've emphasized there on my last slide, that we really need to improve case finding if we want to achieve these goals. And what I haven't discussed at all is how we're going to reach out to these high-risk groups, like people who use injection drugs, incarcerated individuals, aboriginals, etc. We need to do a lot of research into those specific groups and figure out how we can best target those patients. This study has multiple limitations. I think, in the sake of time, I'm going to skip all of them except for the last one, which is that we have not considered any costs. So to treat 11,000 patients per year is going to be very costly. So we need to talk to the drug companies about that. So in conclusion, I just say, with the availability of novel antiviral regimens, I think we can consider, or we can potentially achieve elimination of hepatitis C over the next 2 decades. So thank you for your attention.
Thank you, Rob. Any questions?
So, sorry, Rob. I know you're not getting off that easy. Just curious if there's any plans to do, because I know that the model that you guys have been using, there's the potential to also look at cost effectiveness, as you just said. Yeah. So is there a plan to do some cost effectiveness work in this with that model to look at various strategies? For example, what would be the impact of delaying the introduction of interferon-free therapies or whatnot?
It's certainly something we've talked about, and in an ideal world, we would really like to do. So I think we need to have a little bit more discussion about that. The problem is informing these models with good data regarding utilities, for example, from a Canadian perspective, costs, not only for the treatments, well, that's easy, but the cost of the complications. Really, we don't have a great bit of data which tells us how much an admission for decompensated cirrhosis costs, or HCC, et cetera. So we can do a model, but we don't want to plug it with invalid information, but certainly something we talked about.
Questions? We'll go on to our next speaker. Thanks, Rob.